Today, I'm going to talk about two clinical cases of thyroid emergencies. Clinical case one, key complaints. That was in 2020 during the peak of the COVID pandemic. 49-year-old gentleman, one of my anesthetist colleague, he complained of myalgia for 2 weeks. That has been getting worse, associated with worsening muscle weakness. Finally, he fall at night beside his bed in hostel room. Not able to walk, he had to crawl on the floor to reach to the phone. Finally, he called ambulance. There are few associated symptoms: tremors, palpitation. Colleagues noticed that he has been short of breath. COVID swab was negative, but during the peak era of COVID, he self-isolated. He felt hot, no diarrhea, no weight loss, no thyroid history in the past, or no family history of thyroid disorders. Examination wise, sinus tachycardia of 100 plus, blood pressure stable, SpO2 98% on room air, slight tachypnea, respiratory rate around 20, even though the chest examination was clear. No fever, no exophthalmos, no goiter, no complaint of neck pain, no murmurs. Abdomen is soft, no pain. But proximal myopathy, he couldn't able to stand up from sitting without help of both arms. But after standing up, he able to walk, but a lot of difficulty with severe muscle pain. General body aches, myalgia, all four limbs, motor power 4 by 5. Investigations. DSH suppressed less than 0.005 with elevated serum free T4 three times upper limit or normal. Thyroid receptor antibody positive, which is the autoimmune marker of Graves' hyperthyroidism. Another autoimmune marker, thyroid peroxidase antibody level elevated. This is the actually autoimmune marker of thyroid tissue injury. It's not a specific marker of Graves' disease. Any thyroid tissue injury, it can come up. For example, in Hashimoto thyroiditis, because of lymphocytic thyroiditis, thyroid tissue injury, thyroid peroxidase antibody positive. But if you do the specific Graves' disease marker of thyroid receptor antibody, it's going to be negative. I want to make you clear that these two antibody has their specific value. So, but thyroid antibody level elevated patient, they because of the tissue injury of thyroid gland, there's a potential risk of becoming underactive thyroid in the future if thyroid receptor antibody negative. So diagnosis was made: hyperthyroidism, thyroiditis, secondary to autoimmune Graves' disease. What else? On the renal profile, severe hypokalemia of potassium 2.9, less than 3, which can lead to severe muscle weakness. That we know that. We did the other marker of muscle injury, creatine kinase that came back negative. It means that there is no physical insult to the muscle, but biochemical insult of hypokalemia make the muscle to be weakened. So diagnosis: hypothyroidism, thyroiditis secondary to autoimmune Graves' disease, severe hypokalemia, proximal myopathy with generalized myalgia and myopathy. Diagnosis of familial thyrotoxic periodic hypokalemic paralysis was made. This is common in Asian population. My colleague is background Indian origin with Asian genetic background. This hypokalemia can also happen after heavy carbohydrate meal. Treatment: we start with to control the thyroid hormone synthesis and release carbimazole 20 milligram twice a day. I want to go back to previous TSH level slides. How can we get a dose of carbimazole? So going back to the thyroid function test, there is a one American guideline and up to date that said the T4 level will tell you how much carbimazole is required in your patient. For example, if T4 level is 40, you need to give carbimazole level of 40 milligram. If the initial T4 is 30, carbimazole 30. If initial T4 is 20, use carbimazole 20. If initial T4 is 15, use carbimazole 15. So since his T4 level is 45, I start to use carbimazole level of 40 milligram per day. I split that into two, 20 milligram twice daily. What else? So thyroid hormone is stimulating the beta receptor, adrenergic receptor, both beta 1 and beta 2. Beta 1 receptor is in the heart, causing palpitation. Beta 2 receptor is in the vascular epithelium, endothelium, and at the cellular level. By stimulating the beta 2 receptor, the cell potassium channel will open and potassium from the bloodstream goes into the inside the cell, causing potassium level drop in the bloodstream because potassium go into the cell. So by using the beta blocker, you need to choose the non-selective beta blocker, which is going to act on both beta 1 and beta 2 receptor. By choosing the traditional propranolol, which can block beta 1 receptor in the heart to reduce palpitation, and at the same time, beta 2 receptor, which can block potassium channel, so potassium cannot enter into the cell, resulting in resolving of low potassium in the blood. What else? We need to replace potassium replacement, IV replacement followed by potassium tablet. So 40 millimole of potassium will increase zero point 0.4 in blood potassium level. 10 millimole of potassium replacement will increase zero point 0.1 in the blood. In this case, 2.9 potassium, 40 millimole replacement will increase zero point 0.4, will make it 3.3. This is an example. But please bear in mind that by blocking the beta 2 receptor in the cellular level by the propranolol, potassium cannot enter into the cell. So resulting in paradoxical hyperkalemia, potassium can be suddenly shoot up by replacing the potassium containing drip and potassium containing tablets. So some of the very brave physicians, they use the propranolol alone sometimes they don't want to use the potassium replacement in less severe cases. So this is a one salient point you need to be careful. Watch potassium carefully. With the effect of the propranolol, potassium can be raised by itself without needing potassium replacement. That you need to be careful, especially in day two onwards. What about steroid? Are we going to give steroid? We all know that in any form of thyroid crisis or thyroid storm, steroid is indicated, but this is not the case in this scenario. Steroid is contraindicated in familial thyrotoxic hypokalemia periodic paralysis. Steroid can worsen the hypokalemia, but steroid is one of the treatment or the other form of thyroid crisis or thyroid storm without hypokalemia. You can use IV hydrocortisone, 100 milligram, stat followed by 100 milligram TDS, followed by prednisolone 30 to 40 milligram once daily for 2 weeks. You don't need to taper steroid if you are not giving the steroid less than 2 weeks. You can stop straight. But if you are using the steroid more than prednisolone 7.5 milligram a day for more than 2 weeks, you need to taper down. So, diagnostic criteria of thyroid storm. Is there any precipitant history? So, for example, viral illness, sore throat, marks where we calculated. How high the temperature is important. The higher the temperature, the higher the score. Cardiovascular compromise in terms of heart rate, whether atrial fibrillation is there or not. How severe the heart failure? Just myocardial edema or biphasic struggles or in severe pulmonary edema. How about the central nervous system involvement? Agitation, delirium, psychosis, extreme lethargy, seizures, or coma, which all count. Gastrointestinal and hepatic dysfunction, such as diarrhea, nausea, vomiting, abdominal pain, and unexplained jaundice. A score of 45 is very likely to have thyroid storm. Score less than 25 is very unlikely to be thyroid storm. Score between 25 to 45 is indeterminate. Could be suggestive. But please bear in mind that your clinical judgment is most important. Think someone has thyroid storm, ignore of this criteria. Treat first. Use steroid on the top of antithyroid medication and propranolol. We shall go to the clinical case 2 of the one of the thyroid emergency. 84-year-old woman came in with suspected melena, but she has been taking on iron tablet. She has a shortness of breath, dizziness, fatigue, and forgetful. Past medical history, she has heart failure with preserved ejection fraction, hypothyroidism, cerebrovascular disease, hypertension, asthma, CKD, and chronic anemia due to CKD. He lives alone, partly independent, only needing care once daily. She has been on clopidogrel, ferrous sulfate, furosemide, levothyroxine, lansoprazole, asthma inhaler, allopurinol. This is one of the important slides. Please bear in mind that acid reducing medications can reduce the absorption of levothyroxine. This is not drug specific, it's group specific. So levothyroxine should be taken away from these lansoprazole, omeprazole, pantoprazole, etc. Any mineral containing medication like ferrous sulfate, calcium carbonate, vitamin D tablet, these all can reduce absorption of levothyroxine. end up in under treatment. So usually what I used to do in everyday practice is I ask the patient to take the levothyroxine at bedtime instead of traditionally we used to say to take early in the morning as soon as they get up before taking the breakfast. In reality, to take the levothyroxine as soon as they wake up, at least 1 hour away from the breakfast is not really practical in everyday busy day life, everyday busy life. So later study found out that levothyroxine at bedtime has a better absorption because it's far away from the dinner. That's why emptying time is 2 to 3 hours. So at the time of the bed, there's no food inside the stomach, and there's no chance they can be mixed with other medication. He was stable, not so bad, apart from mild heart failure, bilateral swollen leg edema, laser crabs, JVB elevated. On admission, abdomen soft and tender, even though there is suspect of melena DUX2 on the glove. But later in the day, she developed abdominal distension and pain. Abdominal X-ray suggested fecal loading with pseudo-obstruction. Inflammatory markers start rising. So we invited the surgical colleagues, who requested for the CT abdomen, which didn't show any significant finding. So they concluded that this is the not physical obstruction, some biochemical or some element causing intestine to be lazy through obstruction. But we started empirically moxicillin, metronidazole, and gentamicin AMG regime for possible intra-abdominal sepsis. She deteriorated further, even though initial improvement after getting the antibiotics and fluid resuscitation, etc. Hypothermic, temperature dropped 33, blood pressure stable at the time. Her rate went down to a lower limit of normal, 60 plus. She started needing the 2 liter oxygen to maintain saturation. Review by the surgical colleagues and they confirmed that there is no surgical issue. She became more drowsy. Her rate dropped down to 30s. Also associated with hypoglycemia, blood glucose came down 3, requiring IV glucose. Was any heart failure, and also the whole body has been swollen. We did the AVG to make sure that she is not drowsy because of carbon dioxide narcosis, but carbon dioxide level was normal. Sodium was normal 3 days prior on admission, but it started to come down 124. It's partly because of dilution effect of the fluid overload secondary to heart failure. But combination of hypothermia, bradycardia, hypoglycemia, hyponatremia alert us there's something happen related to thyroid or cortisol. Please bear in mind that thyroid and cortisol are the fuel for all the cells in our body, like the petrol in the car. They cannot work alone. Thyroid and cortisol work together. So any person with hypoglycemia, hyponatremia, you need to suspect cortisol deficiency or thyroid hormone deficiency. There's an ECG, sinus, but not bradycardia yet. Cardiomegaly, not full-blown pulmonary edema, but overload vein dilatation and morbid obesity. There's a paralytic ileus with partial intestinal obstruction. You can see the obstruction of the gut and some fecal loading. We did the thyroid function test. TSH elevated to 246, 250. Upper limit is Normal TSH is 5. TSH elevated 25 times higher than normal limit with undetectable T4 level. So she is in severely hypothyroid. We call the hypothyroid crisis. Diagnosis: hypothyroid crisis. In the past, we used to call as myxedemic coma. But sometimes this term is misleading. Not all the patients are in coma, and not all the patients are non-cardiogenic fluid overload, not myxedema. So later term, preferable term is hypothyroid crisis. Hypothermia, hyponatremia, partial intestinal obstruction, hypoglycemia. So initially, she was conscious, so we treat with levothyroxine. We reverse the hypoglycemia with glucose. We send the baseline cortisol level to rule out cortisol deficiency, but you cannot wait the result to come back. Just give steroid while waiting for the results to come back. IV hydrocortisone to cover for the hypocortisolism. If without giving the steroid, you are whipping the tired horse with thyroxine. Thyroxine cannot work alone, so it's not going to work. Unfortunately, she deteriorated further, needing the higher dependency unit transfer. So she cannot take orally. So we changed to the IV T3, liothyronine, or triiodothyronine, which is more active form, but very expensive, not easily available. I have only used one time over last 5 years. I would say that. So the target after replacement on the T3, within 3 to 5 days, we are aiming to reduce TSH by 50%. You can see that TSH 246 came down to 46. And I'm afraid I don't have the figure in between. We did actually. So TSH beautifully came down. So 3 weeks after levothyroxine, liothyronine initially, but after she regained consciousness, we changed to levothyroxine oral back. So TSH beautifully came down. Never ever use T3 and T4 for the titration of the dose for the levothyroxine or liothyronine. T3 and T4 are very unreliable, very fluctuating in nature, and everybody has their own circadian rhythm, which can fluctuate with daytime. Sometimes it can vary with bioavailability after taking the medication. So we use the TSH for titration of the levothyroxine or liothyronine dose. Unfortunately, she developed hospital-acquired influenza pneumonia and went into multi-organ failure, and she couldn't make it. Rest in peace. So some of the clinical features of myxedemic coma, all of them she had: decreased mental status, hypothermia, bradycardia, hyponatremia, hypoglycemia, hypotension, and precipitating illness of hospital-acquired influenza pneumonia. The treatment of myxedemic coma, as I mentioned before, stand T4, TSH, T3, and cortisol. Levothyroxine in United States, there levothyroxine T4 can be available IV, but in UK T4 can be available only oral. But in both UK and US have the T3 intravenous form available. You don't need to remember the dose. I couldn't even remember the dose. I have used T3 one in 5 years time. So if you need it, search for it. But liothyronine is short acting, so it needs every 8 hours. As soon as the patient conscious change orally levothyroxine, don't forget to give the hydrocortisone. Don't wait for the cortisol result to come back. Other supported measure, if the GCS drop cannot maintain airway mechanical ventilation, fluid and noradrenaline resuscitation if the hypotension or bradycardia, passive rewarming with electric warmer blankets, hypoglycemia to be fight with intravenous glucose. We need to consider empirical antibiotic treatment to cover any infection. Monitor for arrhythmias and treat appropriately. Thank you.